Okay, we are live now, so we are going to actually start the session. Today's session is TIVA Matters, and we will. Okay, we are live. Sorry, now, so guys. We are going to actually start the session. Today's session is TIVA Matters, and we will. Okay, we are live. Sorry, now, so guys. We are going to actually start the session. Today's session. Okay, sorry, that was a bit of, I think, my YouTube channel playing in the background. So we have sort of three topics, or we'd say the three sessions within this today's symposium. Starting off with experiments with TIVA by Harbhajan. We'll be talking about his experience of conducting TIVA in Indian setup. I think this is also related to introduction of remifentanil in India. We did do a symposium on remifentanil. It's almost more than a year now, isn't it, Nitin? And so I think with the availability of remifentanil, a lot of more people trying to use total intravenous anesthesia. Then we'll also talk about a bit about being green. Is TIVA better than inhalational? And Megha is going to cover that. It's part of sustainability. Sustainability is very topical everywhere. So everybody wants to be, carbon neutral or carbon zero. All trusts in, at least in UK, have a zero carbon pledge. And this will be followed by a kind of panel discussion where we will have, in addition to Harbhajan and Megha, we'll have Nitin, who has expertise in neuroanesthesia, EEG monitoring, obviously in using total intravenous anesthesia for neuroanesthesia and other kind of cases as well. So we will start off with the Indian experience, where Harbhajan is going to talk about his experiment with TIVA. Over to you, Harbhajan.
Thank you, sir. Good evening, everyone. So for a person like me who has never given anesthesia with a pump and always has done inhalational-based anesthesia, always believed that doing anesthesia with a pump or with a TCI pump is a rocket science and probably sky is the limit. But thanks to Dr. Nitin and Dr. Subramaniam Mahankali, with whom I got in touch and gathered the courage to get onto my journey of TIVA, especially with the introduction of remifentanil. And I can say that it is the mindset actually which is the limit. So you change your mindset and things become easy. So that's my standard disclosure and a brief outline of the topics that I would like to touch in. That's a brief about the NAPS 5 guidelines, which I will be showing in the videos of how I try to adhere to these guidelines. Now, simply TIVA is a type of anesthetic technique wherein we give all the anesthetics intravenously. We don't give any inhalational agents, no nitrous, no inhalational agents, only oxygen and air to ventilate the patient. Now, this is done by an ordinary syringe pump. Now, if you apply AI and do some automation, the pump can control everything from you, right from the doses to administer for induction and to maintain. And that becomes what is known as a target control infusion. So TIVA can be a choice. If we can do anesthesia outside the OT for almost any specialty, we can as well do it in the theater. Or it can be an absolute indications. Let's say you have a patient of myasthenia gravis wherein you don't want to give relaxant and you don't want to give inhalation, or a patient of known case of the previous severe post-op nausea, vomiting, or a family history of malignant hyperthermia. So these are the scenarios wherein you have to give TIVA, and thus everyone should be trained to administer TIVA. So what is the difference between TIVA and TCI? So as I've already said, For ages, we have used a syringe pump to deliver a drug into the blood as a concentration that is like milligram per kg per hour. So we are just putting in some drug into the blood and hoping that it will go and have an effect on the brain. The only determinant is how much to give over a period of time. Whereas with TCI, what we do is we decide the target that we need to maintain at the brain, and the pump adjusts the flow rates up and down depending upon the various factors which I will discuss later on, and give a very stable anesthesia. So while in TIVA, by an ordinary pump, you may be underdosing, overdosing, or you may be just at the right level of anesthesia. But with a target control infusion, because the pump is doing all this work for you in a much better controlled way, the plane of anesthesia is always stable and uniform. So what I have felt is that there are many people who may not have a TCI pump and many may not have a BIS monitoring. So thus there will be four scenarios in any part of our country or anywhere in the world. That is, you may be doing a TIVA with a ordinary pump with or without BIS, or a TCI pump or with or without a BIS. So there will be four scenarios which I will try to cover. I started my private practice in 1999, and that time I didn't have inhalational agents. And the only type of TIVA that I did was with some, in the absence of fentanyl, was just using pentazocine, midazolam, propofol, and using propofol as a maintenance either by intermittent boluses or by putting it in a drip, or in a very long case, hanging the 50 ml bottle of propofol and connecting it to a micro drip and adjusting it according to the hemodynamics. But then this is something which we know that when you give repeated boluses, there are peaks and troughs of the blood concentration, and you do not have sustained effect. You do not have uniform effect, and this does have hemodynamic consequences. Hence, now there are a lot many drugs which are used for TIVA, but and they have been used in different combinations. But with the introduction of remifentanil, more and more people have started using propofol and remifentanil, or propofol, remifentanil, and dexmedetomidine combination for TIVA or TCI anesthesia. And of course, all these techniques are accompanied by administration of multimodal analgesic drugs. Now, when we give any drug with an infusion, the uh, context sensitivity half time is what we need to consider. So a quick look at this chart and you will realize that remifentanil and propofol, they have the shortest of the context sensitivity half-life. So when you stop administration of these drugs, they will be out of the body very soon, and they will result in a very quick wake up. So because of this shortest context sensitivity half-life, lots and lot of people are using combination of propofol, remifentanil, maybe ketamine, dexmedetomidine, and midazolam. Now, what my interest is of late is to use more and more of propofol and remifentanil for a simple reason that these are the two drugs which have got the shortest of the action. They have shortest of the offset time, and both, when they are given together, result in what is called achieving the almost the ideal anesthetic. The advantages are very clear, that they give a very clear-headed, quick onset, quick recovery, and the patient is ready for discharge from PACU very soon. So there are three type of scenarios wherein which we can give TIVA anesthesia. That is, it could be only a TCI propofol, or it could be only a TCI fentanyl along with an inhalational agent, or it could be a TCI propofol and remifentanil. So I will be talking more about TCI, remifentanil, and propofol. Now, recently I visited to the biggest neurosurgery and the cardiac surgery center of China, just to update with what's happening in global trends. And what I realized is that they are not having TCI pumps at all, and they are doing all their cases with TIVA, with ordinary pumps. And what they use is just fentanyl and a combination of rocuronium and sufentanil in their cardiac centers. And in the neurosurgery center, they also do not have TCA pumps. They have the ordinary pumps, and they use the standard combination for all their patients is propofol, remifentanil, dexmedetomidine, and a touch of noradrenaline. and that provides amazing hemodynamic stability and quick wake-up. So I got inspired from this, and I did a couple of cases in similar way with very good results. Now, when you give any drug intravenously, it goes into the blood, that is known as the central compartment. And from here, the drugs, they move into different areas. So into the brain, that is known as the effect site, or into the higher perfused areas known as the V2 compartment, or the slow moving compartment, that is the V3 compartment. And ultimately, the drugs can get eliminated or they can get metabolized. So with a TCI pump, keeping these various factors in mind, we are able to come up with some equations which can give us a prediction of what will happen when we give the drug into the plasma and what effect it would produce or what would be the concentration. So there are different mathematical models available to determine how the pump would function to give us these concentrations. So a pharmacokinetic model are mathematical model which have been developed to explain what happens to a drug when it is given into a patient. Now, for administration of this propofol and remifentanil, there are a lot many models. So the models which I have been using are for propofol in adult patient is a Marsh model or Schneider model. And for pediatric patient, which I am yet to try, is either Kataria or PedFuser. Now, Eleveld is one model which can be used for both adult and pediatric propofol administration. For remifentanil, we have a dedicated model which we have used that is called Mento model. But this again has got a limitation. It cannot be used if the child is less than 12 years old or if there is a certain limitation with the weight as well. That is, the weight should be more than 30 kg. So in that scenario, you cannot use a TCA pump. You have to use a simple TIVA pump. So if we think of doing a TIVA or a TCI administration propofol and remifentanil, I think the bare minimum that we should know is about Mars, Schneider, and the Eleveld. So most of my cases I have done with Schneider and Minto model. Now, there is a concept of plasma targeting and effect site targeting. So when you go for a plasma targeting, there is a slow rise in the effect site concentration. This is more hemodynamic friendly and it takes time for the levels to develop. Hence, the induction is slow. Whereas in the effect site targeting, the pump will push in almost 3 times the target that you set for the effect site into the plasma so that rapidly the concentration rises in the effect site and there is a rapid induction. Now, the significance of this choosing the effect site or the plasma site is that if you have a thin, frail patient, elderly patient, it's all, or if you are new to this TCI anesthesia, it's always better to go for plasma site targeting. But once you get experience, or if you have got young, healthy patient, or if you are in a hurry to put the patient to sleep, always go for the effect site targeting. But keep in mind that when you go for effect site targeting, you will be putting in a lot of drug into the plasma and there would be some hemodynamic consequences, so be ready to deal with it. Now, how much of and what should be the targets of propofol or for remifentanil when you are giving? So with a simple pump, when we were giving, so with propofol, we were following the Bristol model, so we were giving anything between 6 to 10 milligram per kg, whereas remifentanil we were giving 0.1 to 0.3 microgram per kg per minute of infusion. Now with a TCA pump, we don't do like this. What we do is we set the target that we want to achieve. Now for propofol, anywhere between 3 to 6 is what is required. And for remifentanil, again between 2 to 6 or 7 is the target that we need. So in my practice, what I have done is I usually try to keep between 3 to 6 and then depending upon the hemodynamics, I go up and down. Now, what about the conduct of the TIVA with the ordinary syringe pump? So I have always followed this Bristol model, that is giving a loading dose of 1 milligram per kg and then followed by 10, 8 and 6 milligram per kg for every 10 minutes. Now, roughly it translates into this, that is giving a 5 ml push for on an average for a 50 kg patient. And then for the next 10 minutes, putting the pump at 50 ml per hour, then for 40 ml per hour, and then for 30 ml per hour. So this gives a concentration of something like 3 micrograms of propofol at the effect site. Now with the ordinary syringe pump, so if I translate from milligram per kg into ml per kg, it is that for first 10 minutes you give 1 ml per kg of propofol, and for the next 10 minutes you go on to 0.8 ml per kg of propofol, and thereafter you continue at 0.6 ml per kg of propofol. Now, if we have to do an ordinary syringe pump and a propofol induction, now what I always believed is that it is going to take time. So I devised two techniques for doing induction with a simple pump. That is, what is the rapid technique in which, and a slow technique. So in the rapid technique, what I would do was set the flow rate to 1200 ml per hour. And with this, within 1 minute, I was able to deliver 20 ml of propofol into the patient. And with this, most of the Indian patients would be anesthetized. But if I wanted to go for a slow induction, then I would set the flow rate to either 600 or 300 ml per hour. And with this, I would end up giving either a 10 or a 5 ml of propofol over 1 minute. Now, after this, suppose we don't have a TCI pump and we have to use remifentanil. So that's another challenge that was there when we didn't have the TCI pump. So for this, there was a very simple formula. That is, you multiply the weight by 0.12, and that would give the dose in ml per hour to get 0.1 microgram per kg per hour. And the standard dilution of remifentanil that everyone has advocated is 50 microgram per ml. Now, depending upon the weight, the flow rates would be different. So like for 50 kg, it is 6, for 60 kg, it is 7, and for 70 kg, it's approximately 8 ml per hour. Now, if I have to think about the Indian patients, the weight would be on an average between 50, 60 or 70 kilos. And I remember it like this: as for 50 kg, 6 ml per hour of remifentanil will give 0.1 microgram per kg per minute. And for 60 kg, it is 7 ml. And for 70 kg, it is approximately 8 ml per hour. Now, if you want to go to 0.2, you multiply it by 2. And if you want to go to 0.3, you multiply this 6, 7, 8 by 3, and you get the resulting flow rates. Now, if I have to put this entire information into one simple chart, it is that you use 1% propofol, give around 1 milligram per kg push IV, and thereafter you take the patient to a flow rate of something like 70 to 30 ml per hour, and you can follow the Bristol regime easily. And for remifentanil, if you keep the flow rate between 5 to 25 ml per hour or 50 microgram per ml, you will be between 0.1 to 0.3 microgram per kg per minute infusion of remifentanil. Now, NAPS guideline says that you should have a dedicated IV port for administration of the anesthetic, and this should have an anti-reflex valve. There should be a lure lock, or you should be using the TIVA sets. But unfortunately, in India, it is not available. So this is one device which I have, which is available. It is made by BD company. As you can, there's a cannula, and it has got two ports with a lure lock and an anti-spillage valve. So this is what I have used in many of the cases. But many times it is not available, and it is a bit costly. So for such scenarios, what we do is we use a simple cannula, put a three-way stopcock, and attach both propofol and remifentanil to this dedicated port. And the IV lines are secured with additional tapes onto the forearm. Now, very important is to have a dedicated port for administration of fluids and any other drugs, and a dedicated port for administration of propofol and remifentanil. And though the guideline says that the arm should always be visible, but it has been revised. They said that there should be a potential for inspection of the arm during the intraoperative period. But many times we have to keep the arms by the side, and it is not possible to keep the arm away for so many reasons. So in these kind of scenarios, like when we are doing head and neck surgery, wherein they are going to be standing on both the sides, we keep the arms by the side and we fix all the infusion lines onto the forearm and onto the table, so that they do not get entangled and pulled accidentally. Now, one thing which I tried of late was that after putting the IV cannula, I take a 2-meter PMO line and I fix it onto the pump along with three stopcocks. That is one for propofol, one for remifentanil, and one for noradrenaline. Now, in case I want to add dexmedetomidine, instead of two, I use a three ways here. So in this particular case, we used only propofol and remifentanil. So with this, the advantage is that you are far away from the patient. The connections are right in front of you, and loading the drugs is also very easy. You don't have to go into the surgical area again and again. Now, when you first put on the pump, there are a couple of settings which you have to do. So you have to select the type of syringe, because these pumps, they are primed as per the sizes of the syringe, the internal diameter of the syringe and the outer diameter of the syringe. So the very first thing that you do is you load the drug into the syringe, attach the extension line, de-air it, and then put it onto the pump. Then you put on the TCI pump on, and you select whether you want to do TIVA or a TCI mode. Then if you are selecting TCI, it will ask you to enter the height, weight, gender, concentration of the drug. And then you have to select whether it is effect site targeting or plasma site targeting, enter the wake up concentration, choose the induction method. Some of these pumps, they have fixed induction method, some they have rapid and some slow. And after all these settings are done, you are ready to start with the infusion. Now, this is the kind of interface that is displayed the moment you put the pump on. So you have a facility to use this pump as an ordinary pump or as a TCI mode. So what we do is we select the TCI mode. Now, the moment you select the TCI mode, it will show you some drugs which are primed, which have an inbuilt algorithm to be given by the TCI mode. So in this particular pump, I can use propofol, I can use remifentanil, I can use sufentanil or alfentanil by TCI mode. So your first thing that you do is you select the propofol, then you put the model, the PK model that you want to do. That is the Marsh model or Schneider model. Then put the weight, height, years, gender. Then select whether you want to do plasma targeting or effect site targeting. Put the concentration of the propofol, that is usually 1%. Some centers would have 2%. Put up the wake up concentration. Thereafter, this pump is ready to be used. Similarly, you do the settings for remifentanil. Now, the only difference is that apart from the height, weight, age, gender, etc., here you will select Minto model or as a Elevate model, and the concentration of propofol would be remifentanil would be 50 microgram per ml. In our unit, because of this non-availability of the syringes that are compatible with our pump, we go for 40 microgram, and with this, we are able to deliver at least 50 ml of the drug that we load in the syringe easily, because these are 60 ml syringes that we have. Now, the very first thing after all the pumps are primed and before starting is to attach the EEG monitor, so that you have a processed EEG available and record the baseline base of the patient before any of the drugs are given. Now, many a times, though the recommendation is to use a process ECG whenever you are doing TIVA, so that you are able to determine the depth of anesthesia, it is not always possible to apply EEG electrodes. Sometimes the surgeon would not allow you to go into their areas. So one should always be aware and trained as to how to do TIVA without a BIS monitor. So this is one particular case wherein we were doing a redo brain tumor surgery recently last week, wherein we could not use BIS. So before you give any of the propofol or remifentanil, so in my OT, it is a practice that I always keep a syringe of atropine and ephedrine loaded onto the anesthesia machine. So in case there is any dangerous amount of bradycardia or hypotension, these drugs are available. And of course, the other backup emergency drugs are kept there. But once the patient is induced, at least in the initial days, what I used to do was keep this atropine and ephedrine very close to the injection port that I have secured at the head end of the patient. Now, suppose how to give anesthesia with two syringe pumps. So what we do is we load propofol remifentanil, and I start off either with 0.5 or 1 as the target. So with propofol, it is 1 microgram, the target that I want to achieve. With remifentanil, it is again 1 nanogram per ml that I want to achieve. So always I give propofol first, followed by remifentanil. Now, it is an individual choice whether you want to use propofol first or remifentanil. This is debatable, but my preference is to use propofol first. And so what I do is I start with 1 and I wait for the target to be achieved. And once it is achieved, again I set to 2 and I wait for getting it to 2. And then again, similarly increase remifentanil. So gradually go up and maybe 3 and 3 and 3 or again to 4 and 4. So I keep on increasing by 0.5 or 1 every time the target that I wanted to, that I have set is achieved. And I always make sure that I am talking to the patient and I try to observe at what level of the targets that is achieved that the patient has fallen asleep, there is loss of eyelash reflexes, the verbal contact is gone, and I'm able to hold the mandible and do a bag mask ventilation. So I always make sure that I know that value, especially when I am not having a BIS monitor. So with this way, I get a clear number known to me before before handing over the patient to the surgeons as to what level I am going to be maintaining throughout the procedure to ensure that the patient doesn't have any awareness. Now, this is the information which is very, very important when you don't have a BIS monitor. Now, in this video, I'm going to show how I have done induction for a patient. We started off with zero point 0.5 and 0.5 of propofol and remifentanil targets at FX site. And under local anesthesia, we did the radial arterial line. And then gradually we have increased the concentration of propofol to 1, 1.5 to 2.5 like that. Similarly, remifentanil to 1.5 to 1, 1.5 to like that. And meanwhile, the patient is being pre-oxygenated, has been already pre-oxygenated. So because this is an old man, elderly gentleman, we have gone for a very slow induction in this patient. Now this is a video which is very long, so I have increased the speed and deliberately taken the audio off because it was showing as if sounding as if there is a lot of tachycardia because of the speed. So I didn't want anyone to get confused. So every time I set a target, I wait for some time and you can see how rapidly the target is being achieved. So 1.5 is set propofol and then there you can see it is achieved at 1.4. Similarly, remifentanil target is set as 1.5 and we are trying to achieve, it is still at 1.4. The patient is still breathing spontaneously. So you can see even now the patient is breathing spontaneously. And there we are almost at propofol 2 and remifentanil almost about to be 2 when the resident is able to hold the bag and do the bag mask easily. So this is the minimum target that I am going to make sure that I do not go lower than this during the surgery. So by doing this, I am very sure that this patient cannot develop awareness. The levels may go high, may go more than 2 or 3, but yes, I would never go less than 2 each of propofol and remifentanil. And there you can see the relaxant is given. And because we have attached an extension line, there's a big dead space volume. So we are given a 20 ml saline push after giving. You can see even though the patient has received so much of propofol and remifentanil, almost about 20 ml of propofol has gone. The hemodynamics are fine. Somehow, after going through the charts, I have realized that 4 to 6 is what is required. And because we have not using this, I have, in spite of knowing that the patient has gone to sleep at 2 level, we have seen that there is not much fall in the heart rate and much fall in the blood pressure. So we have deliberately increased to 3, 4, and then intubated. This is another video wherein you can see another patient where remifentanil target was 4 nanogram, but propofol we had taken up to 6. This is a patient for renal transplant. The transplant patient, they will have a lot of tachycardia and hypertension. And you can see here that they are doing laryngoscopy and intubating the patient. And there's hardly any change in the heart rate and blood pressure. There's no tachycardia. So that's the advantage of using remifentanil and propofol together. TCI. Now this is another patient wherein you will see the patient has fallen off sleep at 3:03, and here we were doing BIS monitoring, and you can see that the BIS has gone very low. And when we are intubating, there's hardly any change in the heart rate and blood pressure. Now, many times you will realize that after we have intubated the patient, the preparations would be done to get the patient ready for surgery, and it takes maybe around 10 minutes to sometimes half an hour. So during this time, we don't continue with the very high level of targets. Maybe we drop down to 2.53 of propofol and remifentanil, and we have checked up with the BIS, and we have seen that the BIS is usually low. So this is one thing very, very important. If you don't step down when during this waiting period, the patient will unnecessarily get hypotensive and bradycardic. Now, many times we have seen that when we are waiting for this period, we have gone down on the flow. So we are sometimes worried whether the BIS would be low or not. Especially when we don't have BIS, we are worried that the patient would be getting some kind of awareness. So many times I have correlated in my practice that when we are using this TCI, propofol and remifentanil, there is a display of what rate the remifentanil and propofol is going. And we have seen that propofol is going at 6 approximately 5 to 6 milligram per kg per hour, and remifentanil is going at zero point 0.1 microgram per kg per minute, and the BIS is very fine. And this is when the target of remifentanil and propofol is around 2.5 to 3. So what I uh, re recollected is that after doing so many cases, that if you are giving propofol at 6 milligram per kg per hour and remifentanil at zero point 0.1 microgram per kg per minute, you cannot have awareness. The BIS is usually within the desirable range. This is another video wherein you will see a laparoscopic procedure being done, and you will see that the REMI target is at 4 and propofol is at 3, and there is no tachycardia and hypertension. Usually laparoscopic surgeries, you will see a lot of tachycardia and hypertension. But with remifentanil, I have seen that there is seldom any adverse hemodynamic fluctuation, and there's hardly any need to use a beta lock or an NTG in these patients. Now, how do you do induction if you have an ordinary syringe pump? So what we do is we pre-oxygenate the patient. So there is a separate line for the IV fluid and for the drugs. But in this particular case, both are attached. We are using only propofol for induction here. So you can see they are set to 1200 ml per hour. And the moment you start, it starts pushing in propofol at a very high rate. And within 1 minute, 20 ml of propofol is gone. So once about 10 ml of propofol is gone, the patient has loss of verbal contact, eyelash is gone, and we are able to ventilate. So that's when we have stopped and we have stepped down to a lower flow rate. Now, because this patient's considering the weight of that 1 ml per kg, we have gone down to something like 40 ml per hour in this patient. Now, in the same patient, for maintenance, we have gone down to 30 ml per hour of propofol only. That is 0.6 milligram per kg per hour. That's the video. So as a newcomer to the technique, we wonder how much of propofol would be required, whether it would be adequate or not. So what I have realized is that if you are giving 0.6 milligram ml per kg per hour, then the patient's hemodynamics are very good, and this gives you a very good anesthetic depth. Now, at the start of this, now this is another transplant patient wherein the patient was having hypothyroidism and he was extremely sensitive to this propofol and remifentanil. Now you can see that he has gone to sleep with just levels of 2 each. And when the surgery has started, there's no change in the heart rate and blood pressure. So this gives the indirect evidence that yes, patient is having adequate depth of anesthesia. Now, the biggest advantage of remifentanil that I have felt is that once you intubate, that's the only time wherein you need a relaxant. And you can continue surgery for hours together and not give any more relaxant. The patient would not breathe and would tolerate positive pressure ventilation easily. So this gives us a big advantage towards the end of the surgery. The wake-ups are very quick. That's how it helps. Now, this is another video wherein I will show using both propofol and remifentanil. Now, propofol, we will give a standard induction, but for remifentanil, I have given a bolus that is 0.5 to 1 microgram per kg just before intubation and then gone ahead with the procedure. So you can see we have got this 60 ml syringe. We loaded with 60 ml of propofol and there it goes. So elderly gentlemen around 77 kilos. So we have started at 70 ml per hour. That is 1 ml per kg per hour approximately. And propofol, after the propofol is stepped down, the relaxant is given and the patient is taken onto a back mask ventilation. We wait for 3 minutes. Now, revifentanil is 1 ml per hour. And just before induction, we increase the flow rate. So anywhere between 5 to 25 ml per hour is what you need. And if this doesn't give us a good hemodynamics, then just before intubation, I give a half ml bolus. Now, in my unit, it is a 40 microgram per ml dilution, unlike what everyone says is 50 microgram. So half ml will be 20 microgram. So fentanyl at 15 ml per hour. That is enough. Now, internet. So in this patient, we have maintained with propofol and remifentanil with the ordinary pump. And at the end of the surgery, when everything was done, we applied the BIS monitor and we just to cross check whether we have been giving adequate depth or not. And to our surprise, the BIS was low. So this is one case again gave us the confidence that yes, if you are continuing with the doses that is mentioned in the literature, the patient's BIS would be fine and that there would be no awareness. Now this is another patient. I'll show you the extubation. So the moment you stop this patient, they wake up very nicely, very quickly. So So there's a guideline that before stopping remifentanil, additional analgesics should be given. Otherwise, they will wake up with pain. Now, this was one of the first few cases that I had done. And actually, I was worried about giving additional fentanyl or morphine in this patient. And true it is, he woke up and he said that yes, he is having pain. But yes, when I talked to him in the post-op unit, he didn't have any recall of the intraoperative events. And again, you can see in this video that we have this surgery has gone for about 2 hours. That's the total time that the only relaxant was given. There was no need to give any additional relaxant, and he is woken up very nicely. And even after extubation, he is maintaining good saturation, he is breathing fine. So the lesson that I learned from this case was that before withdrawing remifentanil, you have to give an analgesic. This may sound theoretical, but yes, practically it is very, very important. And this is another renal transplant patient. You see the quick, clear-headed wake-up this patient has on stopping propofol and remifentanil. So this patient I took to the post-op unit and I interviewed her for her experience.
There is no sound, Harbhajan.
No sound. Let me check. Are you able to hear now?
No.
Let me check.
No, there is no sound. It's okay. It's fine. It's fine.
Okay. So what she has got to say is that she had a good sleep. She didn't realize when she dozed off. And when she woke up, she was fine. There's no pain. It was a sleep. There was no dream. And she had a very good experience. So when we are doing TCI, propofol and remifentanil, what I have seen is that you get very good tramline graphs when you plot all the vital signs for the surgery. And it's a very satisfying experience. So every time I did a TIVA, I always thought that there's something may go wrong. I may be underdosing or I may be overdosing, especially when we were using this ordinary syringe pumps. But it's not true. If you adhere to the guidelines, the standard doses, nothing goes wrong. Now, I'll briefly sum up what I have realized after shifting from inhalational to TIVA and TCI. First thing is that whether it is an ordinary pump or a TCA pump, it is very easy. It's just one or two cases that you have to do, and you have a lot of confidence to get almost any kind of a case done. Thinking that a simple syringe pump cannot be used for induction, that it is time consuming is faulty. It is not right. With the TCI, you are very, very specific for that patient because this TCI algorithms, they will take into account the patient's body weight, the various compartments, the distributions, and they will be delivering the drug. So you are offloaded with this responsibility, and the computer does a much better job. There's a precise control, and there's no way that you will be giving less or more unless your targets are not set right. The biggest advantage of this TCI anesthesia is cardiovascular stability. You hardly see any fluctuations in the heart rate or the blood pressure unless there is a surgical misadventure. Very rarely, if you go very high on the propofol and remifentanil targets, especially when you're doing the effect side targeting, there can be some hypotension and bradycardia, but it is not worrisome. Or you can intubate without relaxants. I'm yet to try, but usually in my practice, I have given relaxants for intubation and never given relaxant thereafter, no matter how long the surgery went, whether it was 2 hours, 4 hours, 6 hours, whether it was open surgery or a lap surgery, there was hardly any need for a relaxant. The biggest advantage that I have seen, unlike inhalational anesthesia, is that we get a predictable, quick, and a very smooth wake up of this patient. And the patient just wakes up and says, "Arey, ho gaya? Okay, I didn't realize." They are so happy. And of course, if the patient wakes up fine, you can take your next patient into theater in a much smaller period of time and thereby reducing the turnaround time for the next case. No patient I have seen complaining of post-op nausea, vomiting ever since we have started doing this TCI propofol. The incidence of airway-related adverse events with all these cases till date is zero. I'm so happy with it. Whereas with inhalational anesthesia, once in a while we would end up either holding the mask or sometimes the patient not breathing well, or sometimes the patient having respiratory depression or a need to give oxygen for a long time. Yes, TCI and TIVA, they require some amount of training, but it is just that you need to see one or two cases. Recently, I had one of my friends coming from a different city to get a hands-on experience. So day one, I showed him two, three cases, discussed all the pros and cons and finer points about getting the stable levels. And the next day, he was doing everything on his own. It's so easy. Now, being in private practice and in a private hospital, one need to be very careful with the cost. Now, in a inhalational based anesthesia, the smallest dispensing unit of isoflurane is 100 ml, but you seldom use 100 ml in any of the particular cases. So once you put it in the vaporizer, it is all gone. You have to charge the bottle. So though the patient may not have used the entire bottle of the anesthetic, but with this propofol and remifentanil, you know exactly how many vials you have used. You can in fact show it to the patient every time you do this case. So this is one thing that I like about this TIVA technique. There's transparency in cost. And touch wood till date, I have not had any awareness whether we have done the cases with BIS or without the BIS. In fact, I have been going through the NAV 5 guidelines repeatedly, and I am worried that even when people have used BIS monitor, they have had awareness that though they say that this will reduce incidence of awareness, it will guide you. But even in those cases where we have not used BIS, I have not had any awareness. Just following a very simple guideline that do not go lower than the levels at which the patient allowed you to do a bag mask ventilation in the intraoperative period. Now, these pumps, they always show you a wake up period. Now, for propofol, usually I have seen is it's around 20 minutes. And for remifentanil, it's about 10 minutes. But in real life, what I have seen is that it is half of it. So within 10 minutes, 5 to 10 minutes is at the most that you have to wait at the end of the surgery. Now, of course, we are still in our learning phase. We allow the surgeons to do the sutures, do the complete dressings, the way put all the gown, etc. back, and only then we stop all the remifentanil and propofol. But yes, if you're an expert, you can time it well in advance, and you can have a immediate wake up in less than 10 minutes. Now, one of my surgeon pointed out that, see, you're using so many vials of propofol for this patient. Can you land up in problem? So I did a search and spoke to those people who have been using this technique for very long. And I realized that 6 milligram per kg per hour of propofol for about 48 hours and more is what you need to uh, be touching to have a propofol infusion syndrome, which is very, very lethal. But we hardly do such long surgeries. At the most, maybe 10 hours, 12 hours, not more than that. So we don't consume so much of propofol. So I don't think that there is a need to worry about propofol. So the advantages of this TCI are that there is an automation. A lot of work is done by the pump, so we are free mind. We can concentrate on other activities. There is a precise control. There is a transparency in cost. There's a equivalent capex expenditure for installing a vaporizer and a TCI pump. It is almost the same. So that's very easy to convince the management to go for this additional investment and adopt this technique. The biggest advantage is you're not using inhalational agents. There is no theater pollution. There is no harm to the ladies in the theater. You have a predictable quick wake up, and you are able to adhere to the ARAS protocols of using minimum short-acting drugs and giving a quick recovery. And of course, this TCI is indicated in certain cases like malignant hypothermia, previous PONV. The advantage of this is that you just need to give an relaxant at intubation, and thereafter you don't need to give. So it helps you to give what is to do a relaxant-free anesthesia. So the checklist that I follow for my patients is that always I have a dedicated IV cannula for the anesthetics and for the fluids separately. The cannula is placed and it is flushed and confirmed that it is well in the vein and there is no extravasation. I never rely on a cannula that is come from the ward. All the connections are put tight so that there is no leak. All the lines are fixed to the patient and to the table. The arm is always kept by the side, but if not, we make sure that it is available for inspection if required during the surgery. We inspect the cannula site regularly during the surgery. We inspect the drapes surrounding the cannula to see whether there is any leaking of propofol or remifentanil. Periodically, we keep on checking the floor for any spillage of the anesthetics from the infusion lines. And we keep on inspecting the pumps as well for any leakage or any malfunction. We always keep extra pumps and power cables in the theater. We keep a lot of propofol and remifentanil and additional drugs available should it be required. Many times it can happen when you're doing a long duration surgery wherein you have to repeatedly change propofol. The connections can go wrong. There can be a trauma to the infusion line, and there can be a crack and there can be a leak. So you might be required to change the extension lines. So always have these available in the theater. And of course, lot of availability of propofol and remifentanil. So if I were to give you a mnemonic for a checklist, it is known as press to start TIVA checklist. So P is for propofol, R for remifentanil, E for electricity, EEG, S for setup, and S for settings. So we'll quickly run through that. So always keep one concentration of propofol in the department. Always keep propofol in the top. This is what I learned in last 2 days. We used to keep any arrangement. And of course, you load propofol in the syringe and you prime your pump for propofol. Sometimes you load a drug and you prime it for any other drug. That can be an error, the swapping error. Similarly, for remifentanil, again, you load remifentanil in the syringe, label it as remifentanil, prime the pump for remifentanil, and make sure that the concentration is put right. Always have these pumps adequately charged, keep power cables in the theater, always apply EEG for monitoring BIS whenever possible. Always use a new IV set. There should be a lower lock at both the ends. The set should be primed and then put onto the pumps, and the cannula should always be visible and working. Always the correct details of the patient should be put in the pump. That is in terms of the height, age, weight, etc. Always use the brand of the syringe that is specified for the pump. And always keep an eye on the infusion rate at the time of induction and thereafter during the surgery. So the precautions that I take while administering TIVA and what advice I give to my residents and my colleagues is that have thorough knowledge of the technique and the drugs. Try to have a practical exposure of at least 1 or 2 cases. Good to have a mentorship. Always have a senior person doing the IV cannulation in the theater. I have seen many times the patient comes with a cannula from the ward. I'm so sorry that this is happening in our country. We sometimes we have a poor quality nursing care and the patients come and they give you all sorts of surprises in the theater. Always flush the cannula the moment you place it and make sure that it is flowing fine. There's no extravasation. Always have a separate drug for the TIVA drugs and a separate port for the IV fluids. Always have a dedicated port for fluids and emergency drugs. Always keep all the available emergency drugs in the theater for ready to use. Always have a backup plan. Suppose something goes wrong with your TIVA technique, what will you do? So always keep additional propofol or ketamine or midazolam to take care that the patient doesn't land up with awareness. Or you should always be ready to switch over to a inhalational-based anesthetic technique. Always use BIS, but once in a while the BIS may not perform or you may not be able to apply BIS. So be ready to do any TIVA cases if required without BIS. So what are the things that I think of in future? So one thing that I would definitely like to do is do a study on ketamine. I'm so in love with this drug because of the analgesic properties. But everyone says that when you give ketamine, the EEG goes haywire. So what I think is we'll have a patient who is having a steady anesthesia with propofol and remifentanil, a BIS is attached, and then give some ketamine and see what happens to the BIS. The second thing which I would like to try is going for a single syringe TIVA technique. That is a combination of propofol, ketamine, dexmedetomidine in one syringe, so that the resource constrained hospitals can adopt this TIVA technique in a much bigger way. And of course, I seek opportunity to get guidance from all of you as to how I would convince my scientific and the ethics research committee to get approval for going for a single syringe TIVA. So carry home messages that one should be aware of the carbon footprint from the OT. Please decide what is good for the patient, what is good for the environment. We'll not get into a debate whether TIVA is good or inhalation is good. Please use the drugs judiciously. Adopt newer drugs, adopt newer techniques, newer technologies. Remifentanil is a game changer. It gives you lot many advantages. So if you have a choice, always go for TCI-based inhalation, IV anesthesia, or then go for a simple ordinary pump-based TIVA, or lastly go for manual TIVA. Co-administration of propofol and remifentanil is like giving an ideal anesthetic drug. Always, when you go for these two drugs, it's like doing a relaxant-free anesthesia. And if you choose propofol, ketamine, dexmedetomidine, you can do what is called opioid-free anesthesia by IV route. So a well-conducted total intravenous anesthesia by ordinary pump or by TCA pump will ensure that you do not have a delayed emergence from anesthesia. You do not have any adverse airway-related adverse event or a post-op nausea vomiting. That's something that we desire in most of the patients and all our theaters. With this, I'm open to any questions and answers.
Sir, can we ask the question?
Thank you. Harbhajan, you can stop sharing the.
Yes, sir.
Yeah. So, thank you, Harbhajan, for that lucid presentation. I think it was a mixture of both what is ideally done and what can be done in limited resource centers or centers which do not have all the facilities. I think you have actually put things very, very clearly about what concentrations to be used and how we need to actually prep the patients. And you've given good examples of how practically it can be done. Now, there are few things which are very important to stress when you're using total intravenous anesthesia. Even if you do not have anti-reflex sets, now there are special, TIVA sets available. My suggestion is to actually have two separate IVs, and the delivery of the drug should be closer to the patient. Okay, you do not want any kind of a dead space. And that is when you can actually have kind of patients actually waking up, having awareness and things. So it's always advised that you do actually have the delivery of the drugs very close to the patient. The other thing is that I think one thing you rightly pointed out that because these tubings are heavy, right? And sometimes you may not have access very close, access to the site. It is, I think best thing to is you should have access to the IV site. Okay, but like I said, in some cases it may not be possible by the side. I would even actually go for something like being on the foot side and having the foot or exposing the part of the hand where the IV is seen, because extravasation can still happen. Okay, so having the your IV access by that is not the ideal thing. Okay, you need to actually have it. You need to have a look at that. And I have actually seen in one case where anti-reflex wasn't used, and suddenly a medical student who was there I have posted about it. They said, why is that IV fluid white? Okay, the profile was being increased because patient was trying to wake up. It was being increased, and then they realized that it was going into the IV channel. And I think one thing you mentioned about a case where you couldn't use the PEG monitoring, and Nitin actually has got, and he has published about how you can actually use. I will let actually Nitin talk about it in these kind of cases because he does neuro cases very frequently, and he will tell you the alternative ways of using EEG monitoring, PEG monitoring in such cases. Minal, you got your hand up. Yeah, you can go and ask question. You can unmute yourself, Minal.
Yes.
Yeah,
Yes.
go.
Good evening to one and all. Harbhajan sir, it was a very, very enlightening presentation. Actually, we are using the TIVA technique here to do the neuro cases, but we still don't have the TCI pump. So I would like to ask you, because you also mentioned about how in normal syringe pumps we can actually do TIVA. But I'm sorry, I'm on a call today, so this phone rang. So basically, I would like to ask one question, that is it necessary that when we are doing an induction, then at that time also we should actually be doing it with the help of a pump only? Like if we are doing an induction with a 10 ml propofol direct or a 15 ml propofol direct, is so what is the difference basically, I would like to ask?
There is no difference. It's just a question of mindset. See, for on an average, how much of propofol do you give for induction for an average Indian patient? Anywhere between 10 to 20 ml. So you can give a push manually with one syringe and then continue with the infusion, or you can use your pump itself to give the induction dose and then go on to the infusion dose. So it is a matter of your personal preference. So I have tried both the things in my practice. So there's always this fear that that if you try to induce with a ordinary pump, it's going to take time, but it doesn't, because if you give a 1200 ml flow rate, within 1 minute 20 ml of propofol is gone. And do you give 20 ml propofol for induction to any patient in a neurosurgical patients? No, it is
No.
usually anywhere between 5 to 10 ml, and then
10
maybe another 5 ml, and then something more. So I think what you can do is to cut down the cost of using one additional syringe and one another source of infection. It is that you do everything from the syringe that you have loaded and put on your TIVA pump. Okay, so just
Okay.
set the propofol to 1200 ml. Within 1 minute, it has gone. So what I would do is just allow it to go for 30 seconds. 10 ml is gone. Give the relaxant and then slow down the propofol to 1 ml per kg per hour. That's more than enough.
Yes.
Right. Yes. Fine, sir.
Megha, you can unmute yourself, and then Nitin. Yeah.
So good evening, Dr. Harbhajan. It was a very nice lecture, nice presentation.
Good
So
evening, madam.
extrapolating Minal's question, uh, do you prefer, like some people, they take a fentanyl for intubation and then switch on to remifentanil TCI or something like that. Like they call it the intubation dose of a narcotic.
No.
Do you use it, or do you continue with it? Like
No.
just the
Ma'am,
remifentanil?
we do exclusively propofol and remifentanil to start, right from induction to maintenance. And it is at the end that we take a call to either give fentanyl or to give morphine. So if it is a young, healthy fellow, not much of comorbidities, we would prefer giving 0.1 milligram per kg morphine. And after 20 minutes, waking up the patient. Anyway, around so the way we do the timing is around 10 minutes before the expected wake up, we give morphine, and then we for 10 minutes we continue this remifentanil. Propofol is off, and the patient wakes up within 5 to 10 minutes. But if it is a like say a cardiac compromised patient or something like a very frail guy, or if you think that the airway is an issue, so in these patients, we allow the patient to wake up just by termination of propofol first, followed by remifentanil. And just when we are about to extubate, we give one microgram per kg of fentanyl. and we extubate and assess. If required, give an additional 0.5 to 1 microgram. So that's the trend that we have developed in our department.
Thank you, sir.
Yes, but yes, that can also be done. So there are many people who what they would do is they will give intermittent fentanyls only. So let's say every half an hour they would give some 20-30 mics of fentanyl and avoid a fentanyl infusion, because fentanyl infusion after 3 hours or so becomes very problematic in long duration surgeries.
Thank you.
Nitin?
Yeah.
Nitin?
Yes, we do that, sir. Yeah.
Nitin?
Dr. Nitin is not audible.
Yeah, yours. Yeah, yours. Yeah, you're no, still not. We can't hear you, Nitin. It's something wrong with your, I think, mic. Yeah. So I think hyperalgesia is an issue with remifentanil if you're not using if you're using only opioid technique, because this is an opioid technique, and you need to replace in the end the remifentanil with another analgesic because of its context sensitive half-life is very short. But what my experience is that if you're actually using blocks, so say for example, you actually have a patient who's got an epidural, right? And it has been working fine. You don't actually have to worry about it. Okay.
Yeah.
Another point.
Can you hear me, Dr. Shiv?
Yes, we can hear you now. Yeah.
Sorry about the audio.
Yeah.
I think there was a technical glitch. Well done, Dr. Saini. First of all, I'd like to appreciate you that you have taken up to this new technique. It gives us great pleasure, Dr. Shiv. 1 year before we did this symposium on remifentanil, and now we see it being translated into clinical practice, and people are really using it, and they're doing many things the right way. So, congratulations on that. Some of the questions, I think the one of the comment that Dr. Shiv made was very important, that you need to have a dedicated IV and the port of entry should be as close to the patient as possible. So if you put it away, then your carrier fluid becomes, the delivery agent, and it kind of messes up the whole TIVA. Second thing, giving this fentanyl boluses is a lack of confidence in your TIVA technique. So initially people have seen doing this, but if you get used to the remifentanil, it is as good as any fentanyl or morphine or any of the other opioids. So you just have to get the confidence of doing remifentanil, with induction and going through that. And then giving boluses of drugs and then putting the patients on TCI is not the right technique. If you do TCI, you do it everything with TCI. If you don't have a TCI pump or you don't want to do TCI, then you can use this formulas or the numbers that Dr. Saini was mentioning. So that was about that. And Dr. Saini, for the BIS, when you don't have place to put them in neurosurgical patients, there are alternate places where you can put EG electrodes. Like you can go infratemporal. With the SED line, we do nasal SED line application. So this works well. You can put even posterior auricular. This has worked well. So there is a way around to play with that. But I was very impressed with the technique that you are using as you note down the concentration at which the patients become unconscious. This is a beautiful technique. This is the right way to do TIVA because you are actually studying what this patient needs. So doing TIVA and TCI is another thing, but doing it precisely for that patient is where you need to go, and you're getting there. So what it means is that you are targeting your patient's needs with the TCI dosing. So good on that. It will also give you a hint as to when the patient will wake up. Suppose a 2 at 2 micrograms per ml, if you're seeing that the patient is going to sleep, you might expect that at 2, when you come down on the TCI, that at that level you can start expecting that the patient will wake up. So you can play around with your extubation also. But rest of the other things that you said were very good. Relaxantless, it gives us so many advantages. So TIVA is a good technique. It's a way patients like being put to sleep and like being woken up. And you are doing many things correctly. Some of the other things that I wanted to point out was whenever you are putting the TIVA, you have to make sure that you are putting the right drug in the right model. So this is a technique, this is a mistake that can happen. It has happened with me also. Suppose you put remifentanil in a propofol model, it gives a large bolus of remifentanil and the patient, just goes down and hypertensive. So you have to have your ways around it. You have to have your checklist like color coding, drug labeling, the way you set up the pumps. Like you said, you put the propofol on top and remi on the bottom. That should be like an institute protocol. Everybody should do it the same way. So with TCI in my institute, we at Cleveland Clinic Abu Dhabi do most of our patients with TIVA. Like we are totally on to TIVA now. What we follow is I do not let anybody else load my medicines. I do not let anybody else set up the machine. They can do anything else in the OR, but when I do the TIVA, the dilution and the way I fix my propofol pump and the remifentanil pump is that has to be me, because I need to do that properly, because then it messes up the whole thing. So yeah, these were some of the things that I wanted to comment about. Um, yeah, some problems that you might face is with frail patients, with old patients, with remifentanil, there can be hypotension initially. So you have to go slower. Your technique of going graded is very good. I mean, for a beginner, that is very good. But when you start using TIVA for long with TCI, most people don't do this. They just jump on a level and set the level up. So, but for frail patients, it works very well. Regarding the models, what I can say is TCI is not foolproof. So TCI only gives you a automated, it's like a smart pump. It'll give you a number. It'll target the pump to deliver the drug to reach one number. But all the thing that people say about TCI is all the TCI models are actually wrong. None of them are absolutely correct. So if you try to measure the serum levels of propofol, they do not match. But the thing that you should remember is, even though that all TCI models are wrong, but they work well. So they work efficiently. So you're actually not hitting the target like bullseye, but you're hitting somewhere around the bullseye so that it works for the patient. So it works that way for TCI. So these are the comments that I wanted to make. And regarding the model, I think you're doing with Minto and Schneider or Marsh. I would say if you have a level model, it's slightly better. Eleveld gives you an advantage that you can use Eleveld for all drugs. So you can use same Eleveld for propofol, you can use same Eleveld for remifentanil. So it gives you like one genes fitting all, so like one size fits all, something like that. But Eleveld also accounts for opioid usage. So in Eleveld, it asks you whether you're using an opioid along with your propofol. So it accounts for that. So it's one step higher. So I think if you have Eleveld, try using Eleveld in your next journey. It will be even more rewarding. This is all I wanted to say. Thank you.
Yeah, I
Dr.
have
Nitin,
two
I
pumps.
wanted to ask you one thing. Sorry, sir. Carry on.
Dr. Nitin, I have got two pumps. One is one TCA pump doesn't have Eleveld and one has a Eleveld. So what should be my choice? Which one for Remi and which one for propofol?
Okay, so if you have a level on both, then it makes it easy, because then you don't have to bother about which model and which thing. So it's ideal to have both eye levels, but if you don't have it, I mean, try. Yes, you started playing with it, so you'll get used to it. You'll get used to the level model also. The numbers are not very different from your Marsh and Schneider. Like the targets like 3 and 4 and induction like 5 and 6. What you are saying, those are pretty similar to the leveled also. So mind you, for Schneider and Marsh, there is a difference. So I don't know if you didn't comment on this. So the Marsh actually has a big central volume. So the bolus is slightly higher. So many people prefer to use Marsh for induction. For it gives you a good bolus and a good dose at the beginning. The Schneider is slightly better for frail patients. Like you want a slow graded induction. For then, I would say Schneider is better. So we do a lot of procedures under sedation anesthesia also, like, so there also we use a lot of TCI. So in those cases, what I do is, like, for example, when I'm doing an endoscopy, like if you do an EGD where you need a rapid bolus and the patient should not have much reflex when the scope goes in, so then I use a Marsh for a young patient. But the same thing if I have to do some other procedure like a debridement for an old frail patient, then I go for Schneider with a slow induction and a slow TCI setting. So you have to learn how to play with the models as well. So it will come with experience.
Yeah. So, in continuation to what Dr. Shiv was telling about the dead space, which you have also highlighted, so I would like to add that in our theaters we have what is called VAN-O line. That's a high volume, low pressure tubing, and we have the PMO line. That's the high pressure, low volume tubings. So these are the tubings like the high pressure tubings for the extensions of the
Yeah,
pressure transducers. Okay.
yeah,
So with this, the dead space volume is just about, I think, 1 ml or so. So if at all we have to go away from the patient, we have a cannula and we have this 1 meter or 2 meter PMO line, the high pressure line for the infusions. We don't use the Veno line, which is the low pressure one. So low pressure one, the dead space is almost like 20 ml. That's the one which creates a lot of problem. So this is one modification that I have done. But yes, Dr. Shiv pointed out very right. Better to have the IV cannula on the feet than
yeah.
putting on the
Just
hand
put
and trying to
another
go
extra
away.
IV line and put it dedicated. The problem
Yeah,
is if you connect propofol and Remi away from the patient and have
yeah,
something on the back, like a fluid, like you can be tempted to do this, have a
yeah.
fluid running and then connect
No,
the propofol and Remi.
no,
That's not
no,
acceptable
no,
because it just mixes the whole delivery.
no,
So
no.
yeah,
So it's always one port is dedicated for fluids and one port is dedicated for both propofol and remifentanil. They are attached
that's
onto
that's
one cannula only. Always.
That's acceptable then. And then your idea of mixing propofol and Remy, I would not do
No,
that. So
no,
no
no,
cocktails here. The
no.
problem is that propofol and Remy both have their own, way how they act, and sometimes you might have to play with propofol. You might have to go down with propofol. Sometimes you don't need much Remy also. So you better have two IV pumps running for both
Two
of them,
separate.
so you can titrate them differently. So
Yeah,
at different stages of surgery also. Like if
yeah,
there is no much painful stimulus, you might go down on Remy as well. So
yeah. Right.
Yeah, so another point need to mention about TIVA is that most people will likely try to keep Remy at a constant rate. They know what kind of analgesia, because that will be determined by the surgical stimulus. And then they would vary the propofol as per your PEG, whatever values you have decided to actually have. So that's very, very important. Um, and as Nitin pointed out, wrong drug in a wrong syringe. That is in one of cases. One of my consultant colleague did that. Marsh model remifentanil patient went
Right.
and had a pigeon chest. They couldn't ventilate and they didn't realize it.
yeah, yeah,
Okay. But then that's the advantage. You stop it, and within minutes, everything actually is back to
yeah,
normal. So the other thing about just before Nitin actually came back, I was going to talk about is that extubation. You can actually stop propofol, and you can actually extubate the trachea and leave the remifentanil till that. Then once the trachea is extubated, you can stop the remifentanil, and you have a patient who doesn't cough or so some surgeries where you don't want patient to be coughing at the end of the surgery, that's a common. I mean, I use it for most of them. I don't switch off the remifentanil till I get the tube out and then stop the remifentanil, and they wake up fine. So that's not an issue. Now about PONV, I would actually disagree about that. They don't actually have PONV if using propofol remifentanil. It is known that with remifentanil as well, you can have the post-op nausea and vomiting. So I would actually give antiemetics to all these patients, like give dexamethasone at induction or give the ondansetron towards the end. So just yes, the incidence is probably much lower than when you are using inhalation agent, but it is not zero with remifentanil, propofol remifentanil. Um, I think we are already actually exceeded quite a lot of time, and we've gone beyond. So I'm going to invite Megha to actually talk about sustainability. Where does your TIVA holds in comparison to the use of volatiles, which are most commonly used across the world. So over to you, Megha. You need to unmute yourself.
Hello, good evening. Is my screen visible?
But you're not started your PowerPoint yet. You can only see the PowerPoint, the list of your cases and things.
Yeah. Okay, wait just a minute. Give me a second.
You should always keep your PowerPoint open on your laptop before you start.
I'll just stop share and reshare.
You open your PowerPoint on your laptop first,
Yes.
and then, yep.
Okay.
Go on to this
Full screen. Yeah.
slideshow. Yeah.
Okay, and
Yeah. No, you haven't gone on the slideshow. If you go at the bottom where you see the volume, on the left side of that is this screen, the slideshow. Yeah, that's the one. That's it.
okay. Yeah. So here we go. It's a very good evening. I am Dr. Megha. I'm a practicing anesthetist in Sheikh Shagbut Medical City, Abu Dhabi, UAE. So this is a topic, the green environment is a very topic near and dear to my heart. So I chose to talk on it. Well, it is a very controversial topic, and let's see, what does sustainability mean? So sustainability, by definition, it means to maintain a certain process or a state indefinitely. So what are we looking at in TIVA or any anesthesia, or that it should not harm the nature or the ecosystem, as well it should give us the results. So we will talk about certain terms, and I'm going to brush through these topics because this is a really, really vast topic. So let us make ourselves acquainted with certain things. Then we will see how TIVA can be made sustainable, because this is a topic for TIVA today. And we know to know as to why our conventional or inhalational mode is less sustainable, or let us see how it goes. Okay. So what is inhalational gases and their lifetime? Once we give inhalational anesthesia, it is not metabolized, and most of it is excreted unmetabolized into the circulation. So it either goes into the scavenging system and to the scavenging waste, or if there is no scavenging system, as you all know, it is released to the atmosphere. So it stays in the atmosphere and plays with the ozone layer. And as you can see, carbon dioxide, which we produce, stays in the atmosphere for up to 200 years. It can have that much of lifetime. Nitrous oxide up to 114, desflurane, depending anywhere on its manufacturing, up to 21 years, isoflurane around 5 years or so, and sevoflurane around 1 or 2 years. So whatever is exhaled or unprocessed thing goes into the atmosphere, and it stays in the atmosphere for that much of time, and it plays with the ozone layer and causes what is called as the global warming. So what is the global warming potential? The mass of that particular agent, and in terms of its mass, how much of warming it will create. So they have assigned a global warming potential of to carbon dioxide of 1. So with compared to carbon dioxide, all these global warming potentials, and as you can see, desflurane is the culprit here with a global warming potential of up to 25,040, which is very high, followed by isoflurane, then nitrous and sevoflurane. So for now, it looks like sevoflurane is the one which has a better global warming potential compared to all of these. Now, what it happens is the nature has to take care of all these things, and it leaves behind a carbon footprint. So how do we calculate all this? It's huge calculation and physics, and depends on your machine. So all these calculations is if you are using very low fresh gas flows and a minimum MAC without nitrous oxide and with nitrous oxide. So it is equivalent to what if you are using an automobile, not an electric one, but a regular fuel automobile, and the auto miles that you are going to travel with it. So say, for instance, if you use desflurane with the MAC of 6.6, 6.7% and fresh gas flow of 1 liters, then per minute, then the amount of carbon dioxide that you are going to produce is equal to around 190 miles or around 350 kilometers or so of travel time within 1 hour. So that is the amount of carbon footprint you're going to leave behind. Because we are used to traveling, we are using miles here, and that is how it is usually calculated. With nitrous oxide, it is around 49, and CO gives the least. With 1 liter of fresh gas flow, it will give about 4 miles or say around 8 kilometers or so of carbon footprint. So you go for a shopping trip, and that is how much a sevoflurane would leave the earth warmer by that much, let's say those many kilometers. So that is why inhalational is called bad, or it is called not so environmental friendly. So what I would like all of us to know is how to decrease the carbon footprint in anesthesia. So if all the countries in the world, you are taking, looking at all the countries, and if you consider healthcare industry as a country, then it is the 5th contributor to the global warming in terms of global warming, the entire healthcare sector all around the world. And as per the NHS statistics, 4.4% of global greenhouse is from the healthcare sector. So we are contributing, say 4.4, and in US it is up to 8%. So anywhere between 4.4 to 8% is what our contribution as a healthcare sector is towards this global warming. And that is where the interest comes as to why. Now, how anesthesia is contributing is because most of these gases are used by anesthetists, and that is how we can contribute in preventing this global warming effect. The exact proportion is again a debatable thing, because it all depends on your fresh gas flows and the way the sevoflurane is manufactured. Whereas there are 2 ways sevoflurane can be manufactured, and then one of it causes less global warming, the other one causes more. And how hospital as a unit contributes. So not just the inhalational, as a unit. So let us briefly just summarize it, like how a hospital, any hospital unit would contribute towards global warming. A hospital requires fresh water supply, electric supply, the manpower that travels, the materials, and the green policies that are used in sustaining, or the inventory and purchase department. How sustainable manufacturing, are they using those sources? Is it outsourced from the country? Is it manufactured there? The machinery that goes, the cost of machinery, the electricity, the e-waste that you're producing. And last but not least, the waste management policies of your hospital, because it's incinerated, and again, it causes carbon dioxide and it causes global warming. Now, one of the good part that I saw in Dr. Saini's video is they were using the green sheets. Out here in most other parts, we are using the disposable ones, the single-use ones. So again, they contribute to the plastic waste. So it depends on your hospital policy and in your infection control policy. So blaming solely our sevoflurane or desflurane, if we are using it judiciously and saying that this is causing the global warming and rest of it is not responsible, seems a bit far-fetched. But still, nevertheless, they are the ones causing a lot of global warming. Okay. We'll admit this. Okay. Next slide. So what I mean to say, what I want to tell you is that you never look good by trying to make someone else bad. We cannot look TIVA good by making inhalational look bad, or inhalational look good by making TIVA look bad. See, so that is why I want everyone to have open mind and think as to what is good or what is bad. So now if inhalational has so much of ecological impact, let us see what is intravenous anesthesia or TC or intravenous anywhere. What are the ecological impacts of that particular thing? So as Dr. Saini has said, and we all know, so there are so many things: syringes, tubings, machinery, equipment, the cost. Most important thing is waste management of the unused medications. So there's a lot of waste that comes with it. And last but not the least, the waste management of the syringes, tubings, and the plastics that we are going to use. So the plastic is one of the major culprits, as you know, all over the world. It is not reusable. It is single use. So definitely it contributes to the waste. Now the drug propofol, which is very commonly used. What is the thing? It is like so many studies are there. If you Google and type TIVA and sustainability and so forth, various permutations and combinations, you will find n number of articles and publications about it. So the gist of all those publications is something like 45% of all the drug waste is propofol. You draw in a syringe, it is not used, and you throw it away. Then liver is the only place where propofol can be metabolized. So it does not degrade naturally in the nature. And then it goes, somehow it finds its way into the water and it is toxic to aquatic life. There is something called as persistence, bioaccumulation and toxicity index. So persistence is where it stays in the body, bioaccumulation, it accumulates in the fat, and toxicity is how toxic it is to the thing. So if the maximum is a 3 score to each, and propofol tops the list with a 6/9 score. So if the top score is 9, propofol has a PBT index of 6. Then there are some articles saying that some Amazon forests are deforested to get soybean oil, which is needed for propofol manufacture. So which in turn causes deforestation and causes the global warming and the greenhouse effect. So this is something which we need to keep in mind when we are using things. Everything comes with a cost, and the cost is towards our nature, not only the monetary cost. Okay, so just, Stockholm study, in Swedish study. So they have mentioned the PBTs of various medications. So propofol is, as they have said, it is worst amongst it, because rest of them, even if they have a high PBT, still the relevance is very less, because remifentanil is not much of it is discarded, even lignocaine, bupivacaine, fentanyl. So these are not worrisome. Only the study found that propofol is the one which needs to be looked at, And then there is another study which is in Netherlands. So it's like a Dutch approach. It is a huge turnover center hospital. They calculated waste over a period of 1 week. So this is a picture from that study. They have collected all the unused syringes and medications and everything, and they have measured everything. Of course, they took consent from the infection control, and then there was a certain way they had to collect it. So, okay, all of you are aware of what this is. These are our circuits and the equipment, besides the syringe pump and tubing that we discard at the end of the case. Okay, so everything was calculated, and it is published in European Journal. So like around 135 ml like vials of 2% remifentanil, then 103 vials of remifentanil, because we are talking about these two, and as you can see, these two are the highest in the wastage. And then comes the other syringes, tubing, so on and so forth. So the total waste was around 43 kilos in a period of a week, 1 week. So like this is the amount of ml of propofol wasted was like around 31,518 and so. So you can see that there is a lot of wastage in this. So what I would summarize it, how it goes. So waste over the week was around 43 kilos, out of which 14 liters was of medications. As I said, it's a huge turnover hospital where they are using a lot of TIVA and 14 liters of medications, 29 kgs of plastics. So weekly cost was around wasted was around 7,068 euros per week, and 350,000 euros over a year, extrapolated if you extrapolate those values per week. So this is all taking into consideration actual cost of the medication vial plus the cost to process the plastic waste. So what is cost of anesthesia? It is per case or per hour. Like there are multiple factors. Now, as we all know, inhalational and intravenous, either one requires a specialized equipment. So whether a TCI or a regular infusion pump is a minimum that you would require with an intravenous. Otherwise, we have to go back to some ancient ways like dial-a-flow, or where you could dial it and put it 10 ml, 15 ml. But as you know, it is not very, so equipment costs. A vaporizer company would come and give the vaporizer for free of use if you promise certain number of bottle consumptions a month. So, that is taken care of. Whereas the TCI pumps or the infusion pumps do not promise any such things. You have to buy those things. That is one of the things in costing of the equipments. Plus the models, the programs, that is be it Marsh, Snyder, Eleveld, or any model, the hospital has to pay. Only then those models are programmed. They do not come with the pump itself. So hospital has to pay for them. So for individual anesthetists, just having an infusion pump and doing it with them would be good. But the hospital has to pay for those programs, and it is a maintenance program. So it is given only for a while. So after 2 years or so, you need to renew the contract and so on. So the equipment and the cost. Then the medications. If you go with the consumption and judicious consumption, it has been found that propofol, due to its wastage, was way more costlier by cost. Just because of the sheer wastage. If you see how much is used per patient, then the cost was equivocal. Now, what is caused by the hospital? As I said, post-op nausea, vomiting, and early recovery. So when you are expecting a larger turnaround time, definitely intravenous will be beneficial as the patient meets the discharge criteria faster and goes home faster. And then the cost to the ecosystem. Like at what cost? Even though it is said that this desflurane and all, but if you use it judiciously, as I said, you cannot blame it entirely. Some people may be of the view, I'd rather do a carpooling than not use desflurane or something like that, because it has a quick recovery profile, like equally good. Desflurane also has a very good recovery profile. So for some patients where you do not want them to be sleeping or hungover over the inhalational, then the desflurane is a drug of choice. It is like a magical drug. So cost to the ecosystem is also one of the costs, though hospitals may or may not consider. But nowadays, more and more hospitals are going towards the green thing. So it is a thing, they may accept it. Now, the controversial topic, is it a myth or a fact? So as usual, the studies, the thing is the full life cycle, that is cradle to grave analysis of any given medication is a very difficult thing. And there is no comparative studies like published or taken till date where they actually calculate the propofol in any country, because this is country specific, where the region is using what sources for their electricity and so on and so forth, and the waste management policies of that place. So there is no comparative study at any given place which is more ecotoxic. Some studies have found it that there is waste, and that is why they have extrapolated. So there is no still study. And then policies of that hospital are beyond scope of individual anesthetist. So my hospital has taken away desflurane totally. Nitrous may be the next one out. So it is a good initiative from the hospital itself, and which is beyond the anesthetist selection. Then they say nitrous oxide. Again, sometimes it's a really good drug, but it is very rampantly used in midwifery, where they are using as Entonox. So that needs to be there, because not all patients will be candidates for other types of analgesics. So it's a wonderful drug. So you cannot take it out. Again, for nitrous oxide, they have found that piped gas is causing more leakage. So they encourage use of nitrous oxide cylinders. So as I said, the policies of the hospital are beyond individual anesthetists. So informed choices of individual within their given conditions is a better way forward, because I'm sure the lecture, all of us are listening, are from different places with different, there may or may not be policies. So how will you do your informed choices? They could be based on your infection control policies. Okay. So we do not reuse the propofol. Like once the case is finished, we are just going to throw it away. But it may so happen that if you use theoretically a the non-return valve at one end, you can just discard the further tubings, that this propofol is clean and may be used for other patient. It is not suggested. Even the study which has documented the 43 kgs of waste, they have not reused the propofol. So that is how, and propofol is the culprit in all these things. Then, as I said, patient safety is very important. You do not want to be transferring infection from patient to patient. Okay. So how you can do that? So maybe you will need open the propofol only which is needed for that patient. Do not overload or do not open, so that the waste is minimum. Over the time you will come to know when and how much of propofol are you going to need. You don't go and open like 550 mLs at the beginning of the case. You can open them one by one. It's like something more. Then what is beyond your operation theater? Maybe you could plant more trees. So this is just a overview, something like in the center of this is the non-return valve. So you can put it at both the patient and at the end of the syringe. So, and this is the high pressure tubing that I was talking about. Also, these are the things that contribute towards the waste in a TIVA. So to conclude the last, there is insufficient cradle to grave comparative analysis. So impact of IV versus inhalational, and there is no evidence-based conclusions as to this is better or that is better. It is depending on your patient, the need of the patients, and what is best for the patients. That should be chosen. Do not, see. So the picture at the end, neither you choose your red and you choose your yellow. No, both are not green. Okay. Neither TIVA nor the thing, But we want a greener environment. We want the rainbow at the end of it. So you can choose your boat, and you can choose to be, navigating through and sailing through it safely, and depending on safety of your patient. Okay. So save the planet, and thanks for your patient hearing.
Thank you, Megha, for a very balanced view. You didn't take a side and try to actually balance it, which is very true. Like I'm probably like that. For me, most of my life I've used low flow anesthesia, and I think I hardly contribute much to the environment. But I have also recently done the same thing as what the study you were showing were syringes. And in just a small number of cases, like 6 cases, the amount of propofol. So one of the things I have actually started doing, especially for smaller cases, is to actually use only 20 ml syringe for propofol. So it's less amount of plastic, less amount of the, okay. Despite that, you still have propofol waste, you have remifentanil waste. So that is actually huge. And people need to know that you can't, even with incineration, propofol is still not degraded. Okay. So it goes into the water. So, and it is, again, it is kind of a toxic waste for the aquatic life. So there are, pros and cons, but it is very easy to measure certain things. So like, for example, in UK, by 2024, all hospitals are decommissioned desflurane. Was it a knee-jerk reaction? Probably. Okay. And then like in our new hospital, we do not actually have piped nitrous oxide. And you're very, very right in that. The piped nitrous oxide is probably one of the biggest culprits. So nitrous oxide is actually in newer hospitals. You will not find any more of piped nitrous oxide, but there are plenty of maternity units where they still use Antonox, and that will still continue to be probably used. So phasing that out is going to be difficult. Any comments from the faculty?
Can you hear me?
Yep. Go on.
Hi, everybody. Hello, Megha. Thank you for a wonderful talk. I think it was, as Dr. Shiv Singh said, it was quite a well-balanced talk. I'm glad you didn't take one side. So I think in the probably 170 years of existence of anesthesia, if you look at the history of anesthesia, each and every drug at a certain point in time has had its use. And even now, if for specific cases, there are uses, you can't discount any one of them. As you said, it is horses for courses. I think we need to be aware of what drugs can cause or cannot cause. At the end of the day, for us, in addition to looking after the environment, we have to look after the patients. Okay, so that's what the patients come for. I mean, I think you need to look at the outside the operating theater, how green it is. But if the patient is not alive, or if something is happening because of a specific particular drug, I think we can't be shooting ourselves in the foot just because I have to use this for the sake of what's outside the environment. That's not our priority, I think. If you have to use desflurane, please use it. I think we need to use it. I mean, I still can't be comfortable using a TIVA TCI program in 180 kilo. I don't know what's happening in the body. I mean, what's the volume of distribution? Who is going to tell me? Should I go on for a computer which is telling me, or rather than go for a drug which is time tested? I think, I mean, the some of us telling us, okay, this drug is good, this drug is poison, this drug is not good, I think I wouldn't subscribe to it. I would still go by what you said as to take a balanced view. Nothing is green. There are all shades of green, not thankfully no shades of gray. There's still shades of green. I think a very well balanced talk. Thank you.
I think one of the things people need to learn is to use low flows.
Very important.
We still actually have people who are actually using like 2 liters, 6 liters flows, or forgetting to actually go down to, I think with the newer machines, you can monitor closely what are you delivering. And so you can actually bring down the flows, which reduces the emissions drastically. And there is also reuse of that. There are actually companies which are happy to collect the gases and recycle them. So there are other things as well within the world. And that is very true that TIVA is not for everyone. Like some of the older TCI machines, you actually put in 100 kilos for remifentanil and it'll say, no, sorry, it's not going to accept it. So the models, again, there's no best model to use. We need a lot more monitoring. We need a lot more thing. But again, use it as you would think is most appropriate. And if you want to be really green, and then use regional anesthesia. You don't have to use volatiles. You don't have to use gases. You don't actually have to use anything. I think that is the greenest way. And India is actually far ahead of in this, because I think the number of cases which are done under regional in India is far ahead of any other country. Anil, you wanted to say something?
Hi, sir. Hi, everyone. Just wanted to put your point as well, sir. As you said, there are very good high-end machines. I've seen anesthetists not using low flow. In one of the cases, I was surprised. I did a neurosurgery case with a high-end machine, with a GE machine, what is we have, that actually calculates the amount of CO or ISO at the end of the surgery. And I was surprised to see I used only 23 ml for a 6-hour case. So that is actually helpful to say that low flow has to be used for sustainability. And second point, sir, I wanted to ask you, you do a lot of, regional anesthesia, and you put the patient under sleep.
Yeah.
You use fentanyl for audio cases in these kind of cases.
Sorry, I think the connection
For
was
maintaining.
Say again.
Sir, for maintenance of anesthesia, in a case of regional anesthesia, do you still use remifentanil?
No, not at all. So if I actually use spontaneous ventilation in these patients, most of them, like I'm talking about the peripheral limb surgeries and other kind of procedures, use very low anesthesia with 0.7 Mach. My usage of volatiles is minimal with these kind of things. And I'll tell you another thing. If you actually put a PEG monitoring in these patients, you will find that you can actually go down to almost 0.4 or 0.5 Mach, but the patient will likely not tolerate the airway. Okay, so you require a Mach of 0.6 to 0.7 for them to tolerate an airway. So if you can get rid of the airway, you can actually have a patient at a very low Mach, because I've found it very difficult to actually get patients on a PEG of around 30 when I give blocks, because there is no sensory input coming in. So if you have a dense block, you don't need to. Same thing as with a good working epidural. Again, you don't need to actually use much of anesthetic, whether it's propofol or it is TIVA with inhalation agent. So again, that's where I think monitoring EEG becomes very important. And so that we'll come to that point, and Nitin will talk to us about something on the processed EEG monitoring, which will, I think, people will find useful. And then we can go on to a panel kind of discussions where we can take questions.
Thank you, sir.
Megha, before we start,
Yeah,
Nitin is going to say.
this one, like regarding Anil's question, we have done quite a few cases, where they do facelifts and they do not want any airway distorting the symmetry of the face, especially in the plastics, along with the liposuction and all those things. So there, the TCI is very helpful. You just put a nasopharyngeal lubricated airway and oxygen far away.
Yep.
So they can work, and even without airway intervention, with good TCI and exclusive TIVA, you can do for 5 to 6 hours, and the patient goes home the same evening. Like that is the advantage of this TCI.
So the one important thing is that it's only when you use muscle relaxants that the chances of awareness increases.
Yes.
Okay, if you're using a spontaneous technique, I have never actually used unless I want to actually show someone, you say, look, even with the lowest concentration, we will not reach 30 or 40. Okay. So with spontaneous ventilation, good blocks, you actually don't need to use PEG at all. Over to you, Nitin. So Nitin.
Okay. Thank you, Dr. Chef.
Yeah.
Yeah, so I'll just be talking about EEG and processed EEG just for 10 minutes. This is just to make things simpler. This is not going to be a detailed presentation. So I hope I give you some clinical tips for those who are starting to use TIVA or those who are using TIVA, and to how to understand EEG in a simpler way. So I wanted to share you that this is Professor Stephen Schaeffer's slide and his comment that the top reason for doing TIVA is that patients like waking up from TIVA, and to do more and more cases with TIVA, we need to have EEG monitoring, because if you want to do TIVA, it's something like driving this sophisticated car where you need to have a speedometer. So you need to have the processed EEG to tell you how fast you can go or how fast you're driving, and that speedometer will tell you that. That is the role of EEG. And what TCI does is it is something like cruise control. So it allows you to stay at a constant rate, at a constant speed with the car, and cruise, in a smooth way. So that's the role of TCI. So TCI and TIVA and EEG go together. So this is something which I wanted to emphasize on. The processed EEG, especially when you do TIVA with muscle relaxants, is kind of a mandatory thing that you need to use processed EEG. So why, like Dr. Saini was saying, that with too light anesthesia, we're always worried about awareness, but you'll be surprised to see that if you monitor BIS, and if you see that the usage of propofol will be very high if you don't use BIS, you'll see that you're giving a lot of propofol, and you're giving too deep an anesthesia. So, and this too deep anesthesia or too much of propofol is going to cause post-op delirium and post-op cognitive problems in susceptible patients. Not in all patients, but there is a clear association with too deep anesthesia. So that's why we need to balance our anesthetic to not go too light or not to go too deep. So that's why processed EEG comes into role. So when you look at processed EEG, there are a lot of things that the processed EEG will tell you. There is a raw EEG waveform. There is an index value that is a proprietary algorithmic derived value, which might not always be correct. So so now what we are doing is we are moving away from this number, and we are looking more into the EEG patterns with this DSA. You can see this color density spectral array, and to see the raw EEG waveform. So we are moving away from this number because this number can be affected by multiple things. So these numbers have time and again been affected by multiple artifacts with other non-neurobiological signals, and they're actually oversimplified interpretation of the actual neuronal signal. So what we have started doing now is stop looking at the number and start looking at the EEG waveform and the color density spectral array. As you get used to it, you get more and more accustomed to it, and you can actually stop looking at the numbers and the indices that this BIS or SEDline or entropy that the monitors give. So to simplify things, the DSA, this is a typical DSA that you can see on a SEDline monitor. So there are various bands that you can see. So the band which is closest to the 0 is the delta band, which is the slowest one. And then you have the theta band, which is the frequency of 4 to 8 hertz. and then you have the alpha band, which is 8 to 12 hertz, and then you have the beta band. So in a typical propofol anesthesia, this is like a railway track appearance. This is the typical delta and alpha band that you get. So this is how a propofol and a remifentanil anesthetic will look like. That's what I was telling you, the double delta and the alpha band. In sevoflurane anesthesia, you will have additional theta band also along with the alpha and the delta band. With dexmedetomidine, you get pure delta bandwidth, and with ketamine, you get high frequency EEG signal. So I'll come to that about ketamine. So this is an example how we can use the color density spectral array. You can see as we start off, the numbers are close to 100, and then you push the propofol and you start your TCI, and then you can see that the propofol has kicked in, and then you have this full delta band here. So now there is a delta band, but there is no alpha band. So over a period of time, what has happened is we have come down on the propofol and we have tried to get the alpha band. So what you need to target is to get a railway track appearance or this double band of delta and alpha. I need to target the alpha too. You need to get back the alpha back. So too deep an anesthesia will be only delta band. Try to get the alpha band better, and then this is a perfect color density spectral array picture. So you can titrate your propofol along according to this DSA pattern. So that's what I was saying. Target the alpha. So you need to get the alpha back. Then you get the typical railway track or the double band appearance. Also, this alpha band can go away with some nociceptive stimulus. So it gives you a clear indication that probably your remifentanil is not good enough. So you can titrate your remifentanil according to your alpha dropout. So this was a typical spine surgery where we had an alpha dropout, and then we increased the remifentanil a bit because of the surgical stimulus, and then you got the alpha band back. So remember to target the alpha and to be aware of alpha dropout. So then you get your typical railway track propofol remifentanil anesthetic. And it has been proven with multiple studies that if you have less alpha frequency, then your patients are going to have significantly higher incidence of post-op delirium. So you have to target to get the typical delta and the alpha band. This is an example of a frail aged patient. So here you can see this is the raw EEG waveform. It looks like a burst suppressed very slow EEG because of the neuronal loss and the aged patient. So what we just did was we increased the scale, and then you can see that it is actually not a burst suppressed EEG. It is having all kinds of alpha and delta activity. And very important to also note down that with age you lose the alpha band. So this is a typical example. You can see in this color density spectral array, this is a young patient with a railway track appearance, and this is only the delta with no alpha in this aged patients. So, and multiple studies have shown that aged and frail patients have slow waves, they have dominant delta bands, they are more suppressed, burst suppressed with anesthetics. So, and also you can do pre-induction EEG. So like before you induce your patients, get a proper EEG and the color density spectral array to understand where your patient lies. So if a patient is lying in this kind of a DSA, then you can also predict that this patient might have will be prone for burst suppression, will be more prone for post-op delirium and cognitive deficits. Also, studies have shown that patients with Alzheimer's disease, patients with dementia, also kind of follow this pattern with only deep delta or slow delta bands. So you can actually do a pre-induction EEG and then see where your patient lies, and actually you can predict whether these patients will have post-op delirium or post-op cognitive deficits in the after your anesthetic. So this is how lightening of anesthesia looks like. So you can see here that as the propofol is lightened, you can see the numbers are increasing, and then you can see the railway track increasing in the distance between the railway track is slightly increasing. So you can see this is the typical widening of the alpha and the delta bands. This is actually sometimes called as the crocodile mouth opening, which is seen in the awakening phase. So this is how a typical awakening looks like. So you can see here a delta alpha band, and then with waking up, what is happening is there is a incoming higher frequency waveforms, and you can see this typical crocodile mouth opening like color density spectral array. So this is called the crocodile open mouth pattern for waking up. So, and if you have patients who wake up slowly from this slowly from anesthetic, then you have a slow gradual crocodile mouth appearance, then you have a smooth awakening. And if you have, like this patient has had sevoflurane anesthesia, that's why you can see alpha, delta and theta band, and you can see suddenly that the patient has gone into awakening phase. And these patients are prone for delirium and cognitive deficits. But if you have a slow awakening like this with a propofol anesthetic, you can see that there is a slow crocodile open mouth pattern. So this patient woke up very smoothly after anesthetic. This is the same pattern. So here initially there was burst suppression. You can see these black marks in the color density spectral array. This is propofol induction causing burst suppression. And then you had only delta band, so the propofol was lightened, and then you got the alpha band here in this phase. So in this time, this was a good anesthetic. And then you can see the numbers also that they had gone deeper. The PSI value went below 25, and then when we lightened the propofol, the numbers came back to something where we wanted them, and the typical railway track appearance. So one thing to remember is to avoid burst suppression, we have to strive to not give too much of propofol and cause burst suppression. How burst suppression looks like? On the color density spectral array, it looks like black. You lose the color at all. So there is nothing that can be seen. You can see black gaps. So this is how burst suppression looks like. On the raw EEG, it will look like flat, no electrical activity waveform. So this is a burst suppressed EEG you can see on the raw EEG here. So you should avoid burst suppression, because there is a clear association proven in multiple studies that burst suppression can cause post-op delirium and cognitive dysfunction. So coming to ketamine, we were talking about ketamine. So if you give ketamine at higher doses, you can see that you are getting higher frequency bandwidths here, and the numbers are also increasing, and there is a fast EEG activity. So what we want with ketamine, I think, is to have an analgesic dose. So if you can give ketamine at analgesic dose, that is your subhypnotic doses, you have to give ketamine at a dose where you don't cause EEG changes. So that is what we target. So you give small boluses or run small infusions of ketamine where there are no EEG changes coming in with the dose. Then that's your analgesic dose of ketamine. So you can play around with ketamine also when you add ketamine to your TCI, to your TIVA regimen, by targeting no such fast activity. This was an example where a bolus of 1 milligram of kg of ketamine was given, and you can see that there is a transient increase in fast activity here. So this was probably a higher dose. Then we next gave a hypnotic dose or a analgesic dose of 0.5, and then we didn't have EEG changes like this. So you can titrate your ketamine dosing according to EEG also. Again, dexmedetomidine. So this was a sitting craniotomy case where we were running propofol, remifentanil with LVL models. And you can see that I'm using dexmedetomidine here. With dexmedetomidine, you can use less and less of propofol and remifentanil. So the anesthetic gets even more smoother, and you get good delta alpha bands, and your hemodynamics are stable, and you use less doses of anesthetics, and the recovery is also smoother. So somebody was asking about the alternate BIS placements. You can do this infratemporal. You can go posterior auricular. Even occipital placements have been tried. But this is what we frequently use in our institute. So we go nasal sideline, and this works very well for us. And we have actually done a study where we have compared on volunteers, healthy volunteers. We have compared nasal and frontal typical sideline placements, and we saw that the neurologist was comparing both the EEGs on the nasal and the frontal sideline channels, and they were pretty similar. So we have proven this with this study. So take home message. So what you should do. So maybe in the future you should stop looking at numbers and rely only on numbers, and start looking beyond numbers. Look at more DSA and patterns, and you'll get used to looking at them. Target your railway track maintenance with propofol, remifentanil anesthesia, your alpha delta band, and target to have a crocodile mouth smooth awakening with your propofol, remifentanil. And don't allow burst suppression. and also don't allow alpha dropout, which means that your analgesic doses of remifentanil is lower. So these are the take-home messages that I wanted to give. So this is one paper which we have published where the EEG, all the EEG material that you need for any clinician is given in this paper. And also we have just published this paper with how EEG can be affected with EEG indices can be affected with multiple artifacts inside the OR, and how does the EEG look with these kind of artifacts and non-biological signals. So I'll be happy to share these papers with any one of you who are interested. Please write to me on this email and we can discuss further. Thank you, Dr. Shiv.
That was absolutely brilliant, Nitin. I think you made it really easy for people to understand that. So, yeah, we do actually look at the TSA, but most of us actually just get confused and say, let's go look at the numbers, which are obviously easy. Because I think the way we have been brought up is by looking at BIS, and now we do use PSI, and there is easy like a speedometer, isn't it? So you say, okay, I don't need to actually go into higher speeds. I need to be actually on such and such range, easy to actually target. But you're very right. Actually, recently I was surprised. I actually had a patient who had I probably also had written about this case. Somebody, old patient having parathyroidectomy, and this patient again was like we are using PSI, and she was again on the TIVA. We were using right model, but the scores were very low. However low you actually went with the propofol on remifentanil, her scores were very low. And then post extubation, she was a known asthmatic COPD, a lot of medical problem. Patient trachea was extubated, transferred, was doing fine, and then developed severe bronchospasm, reintubated, and taken to the ITU, where she woke up within an hour, and she was absolutely fine. But I was thinking at that time when the scores were almost, I have got some snapshot which I might share with you sometime, when they're dropping to almost near zero.
Yeah, so what we have realized, Dr. Shiv, is that the numbers are actually not correct, and the machine, the companies have very simplified EEG into a number. So what we want is a simple output, and these guys have oversimplified it. And we actually need to move away from the numbers. And if you start looking more into the pattern, if you start looking more into EEG, raw EEG, you actually can get away with looking at numbers, because many a times these numbers are not true. You might have seen this when there are multiple artifacts, when there is cautery being used, when there are, it goes haywire. So some of the machines and some of the indices don't take into account of all this. So what we are targeting now is to slowly get away from these numbers and look at the patterns. So it's not very difficult. There are some basic patterns that we need to understand, and if we can target that, then we are good. You can, because many times there is a lack of trust also between multiple anesthetists. They come to us, so we being neuro anesthetists, they come and tell us, okay, what about your EEG monitor man? It's showing wayward numbers. So the patient is well anesthetized, and what do you say about this? So every time we have to tell them that stop looking at the number, look at the pattern. The numbers are not always right. They have oversimplified the numbers. So we are, and I think in a right time now, that we need to focus on brain monitoring and EEG, and I think this will become the future. I think we will go more precise on the patients, and I'm convinced that we can dose our patients exactly and give them precise anesthetics when we do more of this EEG and brain monitoring. So there is going to be much of this in the future.
Absolutely. I think, like I say, it's about an eye patching the numbers. Put an eye patch on the number. I like
that's
that.
what we do to our trainees actually. So in our neuroanesthetic training, we just shut the numbers, and I want them to look at the waveform, look at the pattern, and then you open the thing and see. You'll be surprised. Okay, you're getting there. You're actually doing the right thing. So.
And maybe in the future, being AI based, we can actually see that, oh, you need to look at that, and it can actually transpose kind of things that this is what you need for this patient.
Absolutely, absolutely. AI is going to come into EEG interpretation. It's going to make things more simpler. Yeah, some basic things I would like to tell people is look at the baseline EEG. You know, it gives you a lot of hint. So what people don't do is they don't look at it in the beginning. So if you apply an EEG, give the patient some time and you get the number, you see the waveform, you see the pattern, you get a lot of information that this patient, how this patient is doing, whether this patient is doing well, it's a frail patient, it's a dementic patient, Alzheimer's. These kind of patients actually have typical patterns which will alarm you and which will tell you that you can go lower on your dosing of propofol and thus prevent birth suppression and delirium and all this. So
yeah. One of the problems we face in UK is that patients are anesthetized in the anesthesia room where you may not actually have facility to start your PEG monitoring, and then you do it later on. So you lose a lot of information, baseline information. I try to do it sometimes because the modules can be actually moved with the monitoring, and then you can just put the whole module. So we are actually moving towards that, but this was not possible before. Or we actually have a standalone units. So you can actually move the standalone units as long as they don't lose the power. They have power backup. You can actually use them, and you can move along with the page. Like your Massimo PEG monitoring has it standalone, so you can actually move them along with the patient. Okay, I think it is pretty late in India. Then we come to the last part, which was supposed to be a panel discussion. This was to be led by Dheeraj, but unfortunately, he had to travel in an emergency back to India, so he can't be here. He did actually have a lot of questions he would have probably wanted to ask you guys. And I do have a list of some of the questions, but we're not going to go through all of them. But I could actually ask quite a few of them are already covered. But I think what we want to know from all of you is what are the biggest barriers to routine adoption of TIVA if like the PEG monitoring is not available like in India. So they might actually have TCI pump or infusion pumps. I think Mindray is doing a great job by providing this sort of reasonably cost-effective, TCI pumps. So what do you guys think is the biggest barrier? I will start with Harbhajan.
Yeah. So the biggest thing I think is the mindset. We are traditionally brought up that anesthesia means inhalational agents.
Yeah.
So you try to do anything away from it, the surgeon or the administration stands against you. It requires a tremendous amount of effort to align them to the right thought process.
Yeah.
So this is one. Second thing is many of our teaching institutions, they themselves don't have TIVA TCI facilities. So we are not trained for this technique.
Yeah.
And unfortunately, not everybody is there to handhold if you want to adopt this technique. Like I had to travel to Chennai to meet Dr. Subramaniam Hankali. I went to Beijing because nobody was willing to take me into their hospital in India to see how things are being done. So these are some of the challenges I think that we have. Leave aside the capex, for the cost of the equipment. So training is a problem. Then availability of drugs is a problem. Like getting remifentanil into India has been a very tough job for the company. And now that we have it, there are a lot of restrictions on the sale, the transportation, the storage, the usage. There's a lot of documentation involved. So these policies are not friendly. So people say that, okay, why to get into all this kind of headache? Just do the routine stuff and get away with it. So these are some of the things which I think are, contributing to the technique not developing.
Okay, so that actually brings me to one of the questions which Dr. Naresh Paliwal had actually put on the chat. I had asked him to join, but I think he's busy. Nitin, you might be able to actually answer this. So he was asking about dexmedetomidine. I mean, you actually showed that
Yeah.
dexmedetomidine has been available in India for
Yeah.
years and years, and it's a much cheaper drug compared to what
Yeah.
it cost in UK and US. So what about using dexmedetomidine for total intravenous anesthesia?
Yeah.
I'm
So
talking about income
yeah,
replacing remifentanil. Yeah.
yeah. So the thing is, Dexmed came into India much before remifentanil did. So it has been there. So I used to use Dexmed in my neurosurgical anesthesia a decade back when I was training in NIMANS, and then in India, people are using dexmedetomidine, and dexmedetomidine gives you that advantage of cutting down anesthetics, giving you stable hemodynamics, similar to what remifentanil does. So I would say in India, Dexmed is widely used, and people are good at Dexmed. And but Remi has come in recently, so they're slowly getting to the Remi thing also, and then they'll get better at it. But in fact, I would say that the pricing also of Dexmed in India is very economical. So people are using Dexmed very efficiently, and a lot of people know how to use it and use it in their practice for the same advantages that probably propofol, remifentanil, TIVA does. So the same smooth extubation for the stabler hemodynamics, and they're very good at this. So yeah, that's what I want to say.
Mm. Are the models for the target control infusions for dexmedetomidine?
Yeah, so there is a model. It's called Honeyvolt. I don't know if you've heard about it. That's the model for Dexmed. Uh, uh, but even without Dexmed, I mean the TCI model, you can use Dexmed. So you can,
Yeah.
because Dexmed is not very complex drug, and you don't actually depend on Dexmed to give your hypnotic or your analgesic. So it's just like an added, dressing on top of your dish. So you can do without a TCI for Dexmed. You don't need it absolutely, but if you have a TCI, then you can absolutely use it. Honeyvolt is the model for Dexmed.
Yeah. The only thing I think if you look at remifentanil and dexmedetomidine, with remifentanil, you can actually go for relaxant-free anesthesia.
Yeah.
How feasible is it for dexmedetomidine? I don't think it is, isn't it? Am I right?
We actually used to do it for our neurosurgical anesthesia in India when remifentanil was not available, and when they do neuromonitoring, when we can't give muscle relaxant. So our only go-to drugs were propofol and dexmedetomidine, and we used to add fentanyl boluses, and we used to not run infusions, obviously, because fentanyl is not good for an infusion. So
Yeah.
it can be done, but I would say with Remi, it makes it much more simpler and easier. So now you have the perfect cocktail and the perfect ingredients to make that perfect dish.
Yeah, yeah. So I think one of the things with remifentanil is that if you want to do a muscle relaxant-free anesthesia, and there are actually areas where you can't actually use like muscular dystrophies or Malgana-Paris, that kind of patients. You can just intubate the patient with a bolus dose. It's always better to actually start the propofol remifentanil as your TCI model, and maybe actually give a bolus. You can do it both way. One of the questions, and this was being asked in our forum on the anesthesia, our group, this thing, about using TCI for rapid sequence induction, TIVA.
Yeah. So there are two questions that we always come across in all TCI discussions. One is for morbidly obese patients, and second is for rapid sequence induction. Unfortunately, both the situations are a little tricky. You can use, TCI for rapid sequence, but obviously the delivery time is prolonged. It's not that rapid. So I can't answer this it's like it's not black and white.
Megha, you got any experience? Because our obstetric unit actually uses it very commonly.
Yeah.
Yeah.
Okay.
So Megha.
So for the obstetrics, like TCI for a rapid sequence, it can be used like the way Dr. Saini said. I have not used it, but I would be open to using it. Thing is, I don't use TIVA in obstetrics. That is the problem. Like I put on an inhalational because the opioid dose comes a bit late in this. And
Yeah.
remifentanil is also not used even for the sections, elective or emergency sections rather. So yeah, it can be used, not an issue, but not used. I have not used it.
I was actually surprised that they were actually using it in obstetrics. So it's commonly used.
We do use it in our institute also, Dr. Shiv. But the preferred model is MARSH because the bolus dose is higher.
Exactly.
I would say use MARSH and use a higher dose. So don't go by your 5 or 6, maybe go a little more higher because your bolus dosing is actually, good. So, and then you can actually look at once the patient is slightly getting unconscious and then give you a cricoid pressure. So it's not like you can't do it, but there's a way how to do it. So it's not very rapid like the rapid sequence that you do with the hand bolus.
Absolutely.
And to add to that, I would say, like you were asking about the challenges. So my obstetric unit has they have a fixed mindset. They would be surprised if I start using a TCI pump there, and they would doubt it. So it's better everybody's in a comfortable place, especially given the high tension in that scenario, especially obstetrics. So yeah, mindset.
Nagendra?
Yes, I think as the speakers alluded to, especially the use of TIVA with in high BMIs and also in patients with these rapid sequence intubations. I think it's quite. You need to know, as Nitin said, you need to know which model to use. The problem with us as anesthetists, anything new comes, we tend to jump into the bandwagon without knowing completely what it involves. I think the fact that we are using rapid sequence intubation means that it is quite a tricky situation, and the patients might not be physiologically stable for whatever reason. Very rarely you get a physiologically stable patient, and then in these situations, I think I would like to impress for people, especially people who learn TIVA, is that use your time-tested techniques and use what you're comfortable. Do not try anything new at 12 o'clock or 1 o'clock in the night, or even for that matter, 3 o'clock in the afternoon, just because it's something that's there and can be used. I don't think that's the way to go. And again, the point of rapid sequence intubation is to get everything done in a way so that you can go and use other modes of physiology so that the patient can be stabilized. With anything new, you're taking away your focus, and that there comes the problem. And again, in high BMI patients, the same problem occurs. You are not knowing exactly what you're looking at. You're not knowing exactly what all these the programs are dealing with. The LVL is there, but the LVL is fairly new. Not many of us understand it exactly. I think the popular model for most of us is Schneider. I think for across all age groups, Marsh, I think it still needs a bit of validation personally. In a select group of patients, yes, mainly because how these programs have been modeled. LVL has the largest number of patients from which the program has been done, but there are some nuances with LVL. I think we need to be aware of it before you do it. And then if you're using all this in these tricky situations, you need to have something to monitor that you need to what your speedometer is. If you do not have any of it, please do not try, because you're just asking for trouble. That's what my experience would be.
Thank you. I think we are nearly nearly 5 o'clock in the evening, which would be around 8:30 in India. So I'm going to actually ask every one of you one by one as the faculty. So about TIVA training, we did actually just discuss about it briefly and talked about what are the barriers, and TIVA as a training. Unless you're actually seeing it being done with PEG monitoring and everything, how do you think this can be incorporated into the curriculum in India? Because I think Harbhajan gave a very good example where somebody actually, I know the person who actually visited and saw everything being done. But what about our postgraduate students who work in institute which don't actually have even proper drugs? How do we actually make this as a training program?
I think we
Nitin?
as I think we as EPICE Foundation have a huge role here, Dr. Shiv,
Mm,
because we have the experience that the guys in India don't have it, because
mm,
we are using all this for quite a while now. And
yeah,
I think this should be a regular workshop in our EPICE program or EPICE conferences, because we are actually the people who have kind of used it a lot. And a lot of people come and ask us for training, for suggestions, and we cannot give a one-to-one advice every time. Like
yeah,
you send a WhatsApp message, we are busy in our schedule. But
mm,
yeah, I think more and more training programs in our conferences.
mm,
This should be a regular thing now, because this is going to catch up.
yeah,
Remifentanil is going to catch up. TIVA is here to stay, and
mm,
people are not trained in this. Unfortunately, when we trained, it was all volatiles and gas.
mm,
So we have to take this up and as an initiative, as a group, and give it back to our people in India, I think.
yeah.
Yeah, I couldn't
Harbhajan?
agree more with Nitin.
Yeah.
Like when I came here around 11 years back, all that available was remifentanil. So like, and I had to refer back to my textbooks, read about remifentanil before actually
Mm,
starting using it. And I started with a very low dose. And then there's the question that I asked, like people used to say you have to use fentanyl for intubation because the
mm,
pressure response and so on and
yeah,
so forth. But over the time, self-taught, self-learned, and of course, then I saw my colleagues using it. And then now I personally don't use anything for intubation. Like I start with remifentanil, end with remifentanil, and a long acting in the end, or blocks or whatever. So the confidence to start, especially if you're already in a PG, you are not allowed to no access to the drugs.
mm.
Plus, you do not have the background knowledge. So yes, definitely in the workshop, and we are happy to help in our experience.
Okay. I'll take the last comment from Harbhajan. You've been in India and you actually have initiated kind of a training, because that was a very good example of how you can actually help others. So the last one for you, Harbhajan.
What I have done is I have trained most of the trainees in my department, and I have been standing behind the backs of the other consultants and pushing them to do this technique, so that our entire department is used to TIVA. And I have been talking about this technique in our society here at the local level. And I'm
Mm,
planning to do a workshop here so that people can get the feel of it. And unlike the other guys, I am very open. So if anybody wants to visit and see how we are doing, we welcome them with open arms. I think any center, if they are doing this kind of technique, they should make people aware that yes, this is where it is being done, and that they are open to taking people for observership for a day or two, and show them a case or two, and then let them choose and do it. Just stand with them for a case or two, and then next day let them do whatever case they want to do alone, so that when they go back, the queries are settled and they go back confident. This is one. The other thing is to uh, do a very good lecture at the state and the national level in the upcoming ISA. I have, in fact, volunteered to give a lecture and to do a workshop, but let me see how it goes with the with our society. I really don't know. I have been trying to arrange a conference at a local Bhopal level, but it's still in the pipeline. So,
Good. Thank you, guys. I think it's nearly 5 o'clock, a minute later, and I must thank all the speakers, Harbhajan, Megha, and Nitin, for a wonderful symposium and talks. And thank you, Nagendra, Anil, Meenal had joined for some time, and Poonam for joining us today. And thank you, and have whatever time you have for the weekend left. Enjoy them. See you.
Thank you,
thank
Saini sir.
you.
Thank you, Megha. Thank you, Nitin.
Thanks.
Thank you
Thanks,
so
everyone.
much.
Thank you.
Very. Bye bye.